Hello again, everybody. I called this lecture Acute Gallbladder because I want to talk about all the acute things that can happen to the gallbladder, most of which are painful. You may, when you think about acute gallbladder, or acute right upper quadrant pain, you may be thinking about acute cholecystitis, and that should be at the front of your mind. However, not all of these things we're going to talk about necessarily have significant inflammation, and not all of them involve stones. And so I just figured acute gallbladder would be the best way to term this big group of diseases that cause pain in the right upper quadrant due to the gallbladder. Alright, so with that, we will talk about the anatomy of the gallbladder, which is pretty straightforward. We'll talk about the stones that can form, and then some of the acute problems of the gallbladder. There's 6 of them, and they're very, very important to differentiate because while the names sound the same, they are very different diseases. We'll talk about the 3 of the big complications that can come out of really any of these first 5, and then some algorithms to sort of sort this out in your mind and figure out how you're going to approach this when you have a patient with right upper quadrant pain. Acute cholecystitis should be number 1 in your differential when you have a patient, especially an adult, older female adult, coming into the ED with right upper quadrant pain. That should always be first in your mind. So these are things that you're going to see frequently or be testing for frequently. So the anatomy of the gallbladder, don't worry about memorizing fundus, body, all this stuff. You've got your gallbladder here. The neck is just the area between what is called the body and what is called the cystic duct. But I don't know if there's really any strict definitions of when it becomes the infundibulum and when it becomes the neck. As far as you're concerned, you have a body, you have a neck that connects it to the cystic duct, and then the cystic duct meets up, remember, with the common hepatic duct. The common hepatic duct is getting bile from both lobes of the liver, and when it meets up with the common hepatic duct, it becomes the common biliary duct, or the common bile duct. And after that point, it receives the duct from the pancreas and becomes the ampulla of Vater, and empties into the duodenum, the second portion of the duodenum, through the sphincter of Oddi. There are 3 different types of stones that are commonly formed. The first one, cholesterol stones, is the most commonly formed in the US, and cholesterol is a major component of it. And patients who have higher cholesterol levels, have a higher intake of cholesterol, are more likely to develop cholesterol stones. Now, some people just have a lower likelihood or a higher likelihood to develop stones just because of their genetics. So not everybody who has stones is whooping down the burgers and fries at McDonald's. That's not how it is. But if you take in more cholesterol, you are more likely to get cholesterol stones. Bilirubin stones have an increased incidence in patients with hemolytic disorders, and if you think about how that could be, it makes perfect sense because when you have bilirubin in your blood, and so when you hemolytize, and you're getting indirect bilirubin, and after that, then it'll go into the liver. So your indirect bilirubin goes up, and the result of that is that you can form stones. Calcium bilirubinate stones has an increased incidence in patients with infections or inflammation of the biliary tree. Alright, so this first one is not really a disease, but it's something that is important to know about because you may get a question about it on the USMLE. So, for instance, a 44-year-old is getting a ultrasound of her liver to check for cysts because to check for polycystic liver disease, and as you note the gallbladder, you note a 1 centimeter stone in the body of the gallbladder. I'm just taking that off the top of my head. What would you do with that? Well, this is a woman who has no other symptoms. She's got a stone in her gallbladder. What do we do with it? Nothing. We don't do anything for patients. Even if they have stones, we don't do anything on patients with gallbladder stones if they don't have symptoms. Now, it's good to know, and you should certainly advise the patient. You're not going to be looking at the gallbladder and be like, oh, look, there's a stone, and then not tell the patient. You're going to tell the patient you have a stone in your gallbladder, because then down the road, if they come in with right upper quadrant pain, and they may never come in with right upper quadrant pain, then you have a high likelihood that right upper quadrant pain is due to the gallstone. So you'll want to tell the patient, but you're not going to do anything prophylactically or certainly surgically to get rid of this stone. And the only exception to this is if the gallbladder is calcified, which is a totally different disease entity itself. So you may discover that on routine exam. That's an indication of cholecystectomy, and that happens from having multiple stones in the gallbladder. But if you just see a stone in the gallbladder, the patient's asymptomatic, don't do anything. Nothing. So acute problems of the gallbladder include the most common one, which is acute cholecystitis, Acalculous cholecystitis, which you tend to see in the ICU because it tends to happen in sick patients, biliary dyskinesia, Choledocholithiasis, acute ascending cholangitis, and biliary colic. Alright, so here's our vignette, and our vignette is pretty much going to be the same patient, just with some minor changes. So you can see how these are all very similar, but there are some variabilities on their presentation. So a 46-year-old woman presents to the ED, and that's usually where they go when they have this pain, complaining of nausea and pain in her abdomen for the last 6 hours. She denies any changes in bowel habits or blood in the stool. She has no surgical history. She is mildly febrile at 100.9 degrees Fahrenheit, blood pressure 135/90, heart rate 103. Physical exam reveals an overweight female in moderate pain. Abdomen is tender to palpation in the right upper quadrant, but non-tender elsewhere. The abdomen is non-distended. Bowel sounds are normal. Okay. So for labs, if you're taking step 2, you'll be given these, more than likely. If you're taking step 3, you're going to know these are the labs you always need to order up in a patient with right upper quadrant pain. So you're going to want to get a CBC. In patients who have problems with stones obstructing their gallbladder, which we're going to see that's what this is, they'll have an elevated white count. So she's got an elevated white count of 10.5, elevated neutrophils, so we know this is an infectious process. She's got a CMP that's mildly elevated for T-bili and AST. Her amylase is normal. That's good to know because it means that there's nothing going on in the pancreas. Her beta-HCG is normal. The reason we do a beta-HCG in women in this, as we're going to see, is because we are going to be administering antibiotics. And it's good to know both for the surgeon and for the internist to know whether or not the patient is pregnant, because that's going to change what medications you're going to give. The urinalysis is unremarkable. Chest x-ray is unremarkable. EKG shows sinus tachycardia, which is a lot of the times you see that in pain. So the differential diagnosis in this woman, of course we think acute cholecystitis. She's 40, she's overweight, and she's, I guess we don't see anywhere here that she's fertile, but she does fit the fat female fertile and 40. So she fits 3 of those. So of course we're thinking acute cholecystitis first, but some of the other things that we're thinking, of course, are hepatitis, acute hepatitis, like hepatitis A that you can get from food. With hepatitis A, we would see the elevated CBC and elevated neutrophils. However, you would have more disturbed liver values. You can get appendicitis in your right upper quadrant, but usually that's in pregnant women. You can get right lower lobe pneumonia, and that can present as right upper quadrant pain. And so that's why we get a chest x-ray, and the chest x-ray is unremarkable. You can have peptic ulcer disease. That's another thing that this could present as, but this doesn't sound like peptic ulcer disease because this is in the right upper quadrant. Peptic ulcer disease tends to be epigastric. Plus, with peptic ulcer disease, you tend to not have an elevated white count and the elevated T-bili and elevated AST. Another thing it could be is pancreatitis. With pancreatitis, your amylase would be elevated. And then finally, a UTI is another thing that we're always concerned about in any woman with abdominal pain, because that may be really flank pain that she's just experiencing more in her abdomen, so you'll want to get a UA. So a beta HCG and a UA are pretty much women only. And then an EKG, you may or may not go with this. In an older patient, always get an EKG when you're having right upper quadrant pain, because we're always concerned about MI, but it's optional, really, in a patient with right upper quadrant pain who's younger. If she just has sinus tachycardia, that's probably because the pain is causing a fight or flight response in her. So CBC, CMP, amylase, chest X-ray, and everybody, beta HCG and UA, and beta HCG in a woman of young childbearing age. Then a UA in women, and EKG in 40s, 50s, and older. That would be my recommendations. Okay, so the most likely diagnosis here now is acute cholecystitis, and we know that because of that she's mildly febrile, she's overweight. The abdomen is tender to palpation in the right upper quadrant, and if you were to palpate her right upper quadrant, what you'd want to do is press lightly and have her breathe in. And if the pain comes when she's breathing in, that's a Murphy's sign, and that's correlated with acute cholecystitis and some of the other gallbladder issues. But what's also important is what's not here. So she doesn't have any changes in bowel habits or blood in the stool. So it's more than likely this is not an obstruction. The abdomen's not distended, and the bowel sounds are normal. So this isn't an obstruction. She also has no surgical history. So I wanted to put that into place right away. Okay, and then with her CBC, as I kind of already mentioned, her white count is elevated with neutrophils, so that suggests an infectious process, a bacterial process. And then mildly elevated T-bili and AST. Okay, so this is acute cholecystitis, and of course your next best step is going to be a right upper quadrant ultrasound. But what is acute cholecystitis? It's inflammation, usually with overlying infection in 75% of the patients, due to obstruction of the gallbladder neck or the cystic duct. So why do we get infection when it's just a stone blocking the gallbladder? When you have this direct pressure from the stone, it causes ischemia of the gallbladder, localized ischemia, because it's compressing on the arteries that's supposed to supply it. You also get an impaired venous return as well. And so this leads to ulceration, ischemia, and what can happen from that is that you can get bacteria moving in from there. So what we're concerned about here now is the integrity of the gallbladder. The symptoms are fever, nausea and vomiting, right upper quadrant pain and tenderness, and Murphy's sign. Labs reflect inflammation, and many patients will have an elevated T-bili and AST. It's not uncommon for a patient to also have an elevated amylase in about 10% of patients, or to have an elevated alkaline phosphatase. But T-bili and AST are what you're primarily going to see. The best initial diagnostic step when suspecting an acute cholecystitis is a right upper quadrant ultrasound. Remember that your differential diagnosis includes acute hepatitis, right lower lobe pneumonia, pancreatitis, already said that, UTI, pyelonephritis, and MI. So we kind of ruled that out right away with our labs. Okay, so this is a normal gallbladder doing a right upper quadrant ultrasound, and when you do your right upper quadrant ultrasound, when you're looking for the gallbladder, a lot of times it'll help to push your ultrasound device in a little bit, just kind of gently pressing the patient's right upper quadrant. You're doing it right where you would check for a Murphy's sign. And when you do that, if the patient says, "Oh, that hurts," that's called a radiologic Murphy's sign. So here's a normal gallbladder. And what I want to point out is, of course, the gallbladder here, which we don't see anything in it as far as on the ultrasound, and then the wall of the gallbladder. So the wall of the gallbladder is just this echogenic line that comes around the gallbladder. You see it a little better here because it's up against the parenchyma of the liver. But here's your wall of the gallbladder, and you can measure it on your ultrasound using your devices on your ultrasound. They're all different, but see, they're measuring it here from here to here, and it'll come back saying 0.8 millimeters, and that's normal. Anything below 3 millimeters is normal for the gallbladder. And then here you also see the duct. If you look really closely, you can see some smudging and stuff, and that's actually bile. Okay, so here's another view, and this is good because you can see from the long view. Because remember, the gallbladder is sort of a long structure, but circular in the middle. And then so here's your circular transverse view. So this is if you were looking at it through the neck, and this is as if you were looking at it anteriorly. Okay, so this is acute cholecystitis. Now, while we don't see the stone here, and that's going to be, I know, the first thing you're going to want to look for, and it is an important thing to look for, so there's other things that are also important. So when you're looking at the gallbladder, you want to look for fluid around the gallbladder, and that's because, remember, of that edema. You've got pressure from the stone, and it's backing up the venous return. And so there's going to be edema around the gallbladder because it's going to increase the hydrostatic pressure. It's like ascites in the liver, because in the abdomen, because the liver is blocking the outflow there. It's like pulmonary edema because the heart's not pumping out from the lungs, so you get edema in your lungs. Same thing here. If you can't, if you've got a stone compressing on a vein, and it always does, you're going to get a certain level of fluid around your gallbladder, and that is pericholecystic fluid, and there's a lot of it right here. Another thing you see is, remember that echogenic line? Well, it's right here, but you see also more wall. This is inflammation of the wall. It doesn't all look like that echogenic line, but you do see inflammation right from here, where my arrow is right now, to here. So you'd want to measure it. I don't know exactly how much it is here, but it looks definitely over 3 millimeters. Here's another one. So this is a little better to display the increased gallbladder wall. You can actually see it looks more confluent, but here's the gallbladder wall right here, definitely more than 3 centimeters. You got your stone down here. Your neck is right here. Okay. And then here's your stone blocking the gallbladder at the neck, and then these blue lines are pointing to pericholecystic fluid. Here's another one. So here's the stone right here blocking the neck. You can kind of see it in the, it's also kind of in the gallbladder too, but it's blocking the neck. And so nothing can get out of the gallbladder. What you also see here is a thicker wall. I want to go back and see if okay. So this stuff here, this is the stone, this white stuff. This kind of gray stuff here, this is not inflammation from the wall. This is what's called sludge. And sludge is just bile that's kind of dehydrated down. And so it's not bile, but it's like bile if you were to pull out some of the fluid from it. So that's sludge. And you see sludge a lot of times on when you're looking at acute pancreatitis. So here's a little sludge here. Okay, and then here is another obstructed gallbladder with a lot of sludge. You even see a stone inside the sludge, and then possibly this may be the stone here obstructing the neck. So here's another acute cholecystitis, and it looks like right here is where the radiographer is measuring the wall, and this would be the best place to measure it. You want to measure it at the thickest point. So for diagnosis, as mentioned, the best initial step is ultrasound, and this is the best and tends to be the most accurate step anyway. The treatment for acute cholecystitis is cholecystectomy. However, we don't just wheel the patient right in for cholecystectomy right out of the ER. So what we do is, and this is important to know for step 3, admit the patient, give them IV fluids, and broad-spectrum antibiotics. And those broad-spectrum antibiotics should cover, because remember we're in the abdomen, should cover gram-negatives and as well as anaerobes. So something like metronidazole to cover the anaerobes, as well as ampicillin and gentamicin to cover the gram-negatives. There's lots of answers. That's not the only right answer. There's many different things you can do. The patient should also be placed on NPO, obvious because they're getting surgery the next day or the next 2 days, and monitored for 48 hours. Why do we do this? Surgeons don't like to operate on anything that's inflamed. It makes things harder to do for them. So if you call your surgeon from the ER or wherever you're at, if your patient has diagnosed cholecystitis and you tell them, I want my patient operated on right now, they're probably going to say, no, I'll do it on Wednesday, or if it's Monday, or I'll do it on Thursday if it's Tuesday, because they don't like to operate on inflamed material. What they'll do is they'll tell you to observe the patient. You'll observe the patient's symptoms. Most patients, their symptoms will resolve just with the medical therapy you're giving them. So the IV fluids, broad-spectrum antibiotics, bowel rest, all of that will usually make their symptoms better. And after their symptoms are better, what that means is that the inflammation has gone away. But after their symptoms are better, then the surgeon will operate on them. However, if their symptoms continue after 48 hours or it worsens, then you call the surgeon and they will see if they need to operate on them. And if it continues, it's just because you're not getting any resolution. If it worsens, it's because there may possibly be a complication. It doesn't happen very often, but the idea is here that it's better to wait and in most patients, better to wait and watch and try to resolve the symptoms before we operate on them. But if we have to, they can be operated on faster. So that's usually what the guidelines are, and the USMLE will expect you to know that not all patients with acute cholecystitis, especially if they're otherwise healthy, they don't need to be operated on right away. You should initially admit them, place them on fluids, broad-spectrum antibiotics, NPO, and monitor them. And it does not need to be in an ICU setting unless there's other things there. Okay, here's a vignette. Now this is a little different. A 71-year-old man who is presently hospitalized in the ICU complains of new severe abdominal pain. He was presently being treated for left lower lobe pneumonia. He was admitted 4 days ago when his daughter brought him. He was confused, febrile, and hypotensive. He has since stabilized on IV fluids, piperacillin tazobactam, and azithromycin, along with chest physiotherapy. He has no other GI complaints, apart from the right upper quadrant pain. On physical exam, you note exquisite tenderness in the right upper quadrant, no peritoneal signs or abdominal distension. He has been having normal bowel movements and has been passing gas normally. He is mildly febrile at 100.6 Fahrenheit, but his vitals are otherwise normal. So we may want labs. So our labs come back. CBC is white blood cells 11.4, which may not be unusual because he's got pneumonia. Elevated neutrophils. CMP shows mildly elevated T-bili and AST. Now, if this white blood cell count was coming from the pneumonia alone, we wouldn't have a mildly elevated T-bili and AST. So this is not normal, and this deserves working up into. Amylase is normal, good. We know his pancreas is okay. Chest x-ray shows left lower lobe pneumonia, consolidation, improved from yesterday. But look, it's the left lower lobe, so this is not going to be giving him right upper quadrant pain. If it were right lower lobe, that might possibly be a cause of his pain. EKG shows normal sinus rhythm. So now that we know he's got a mildly elevated T-bili and an AST that's high, what's the best next step? It is just like what we would do in any other patient with new right upper quadrant pain. It's going to be a right upper quadrant ultrasound. And a right upper quadrant ultrasound is significant for wall thickening, but there's no stones or pericholecystic fluid visible. So all there is wall thickening. What's the diagnosis? And just with this, you can make a diagnosis, and that diagnosis is acalculous cholecystitis. And the best test to diagnose acalculous cholecystitis is right upper quadrant ultrasound. So acalculous cholecystitis clinically appears similar to acute or calculous cholecystitis if you're differentiating the two. However, there's a few things different. Patients with acalculous cholecystitis tend to be patients who are already in the hospital for other reasons, and I'm not saying other reasons like they got a cut on their arm and they need stitches. I'm talking about patients who have undergone some serious trauma. So they've had sepsis, they've been burnt, they've gotten into a car accident and required bone surgery. They were dehydrated. They are on mechanical ventilation. All of those things are severe stresses on the body, and they put you at risk for acalculous cholecystitis. So severe illness is a major risk factor for acalculous cholecystitis. So if you ever have a sick patient who's in the hospital for other reasons, now complaining of right upper quadrant pain, you are concerned of acalculous cholecystitis. And the reason that you're really concerned right off the bat is because unlike the regular garden variety acute cholecystitis with the acute acalculous cholecystitis that we're talking about here, this has a higher mortality rate, and it can go up to 50%. When you're looking on labs, they appear the same as if you were to have regular cholecystitis. And the best initial diagnostic test is the right upper quadrant ultrasound. So this is pretty much just like regular acute calculous cholecystitis. But the difference is that in the history, they usually have something that is enough wrong with them that they're in the hospital for other reasons, or they have this finding when you do your right upper quadrant ultrasound where you don't see any stones, but you do see thickening of the gallbladder wall and possibly pericholecystic fluid. The treatment for these patients is not watch and wait like we do for calculous acute cholecystitis. The treatment for these patients are to immediately remove their gallbladder. When I say immediately, I mean as soon as we can. Because most of these patients are sick, they're usually going to need to be prepared for surgery. And so as quickly as we can, we want to try to get their gallbladder out as soon as it's safe. There's another treatment that you can do if they're not surgical candidates, and a lot won't be who are in ICU settings. You can remove their gallbladder percutaneously. However, that's going to require a very, very, very skilled surgeon who's familiar on how to do that. Broad spectrum antibiotics should be started right away on these patients before, as soon as you've diagnosed it. IV fluids should be started. They usually are already started in patients who are already sick. And then, of course, they should be NPO. So here's a right upper quadrant ultrasound showing gallbladder thickening. And you also see some pericholecystic fluid out here. So the wall thickening is right here, and the pericholecystic fluid is here. You might even have some fluid here. But you don't see anything obstructing the neck or the gallbladder. Now, of course, you couldn't diagnose it just on this alone. You'd have to go and visualize the ducts and everything. But this would be an instance where we don't see a stone, but we do see pericholecystic fluid and gallbladder wall thickening. And that's what you would see in acalculous cholecystitis. Here's another one. So this is a nice view of the gallbladder here. We've got some wall thickening and no stones. Okay, here's a vignette. So now we're going back to our 46-year-old woman who had acute cholecystitis, but now she's a little different. Now, let's say in an alternate reality, she's presenting in a different way. 46-year-old woman presents to the ED complaining of nausea and pain in her abdomen for the last 6 hours. She denies any changes in bowel habits or blood in the stool. She has no surgical history. She's mildly febrile at 100.9, so pretty much the same so far. Blood pressure 135/90, heart rate 103. Physical exam reveals an overweight female and moderate pain, so pretty much the same so far. Abdomen is tender to palpation to the right upper quadrant, but non-tender elsewhere. The abdomen is not distended. Bowel sounds are normal. CBC, CMP, amylase, and beta HCG are unremarkable. Okay, so this is different. The last one had a CMP that showed an elevated amylase and an AST, and a CBC that showed an elevated white count. Right upper quadrant ultrasound is ordered and is unremarkable. So what's going on? So now we have the same patient who's presenting the exact same way, but her labs are normal, and her right upper quadrant ultrasound is normal. So we think, just based on her history and symptoms, she's got acute cholecystitis, but the labs say no. This is biliary dyskinesia. So biliary dyskinesia is a disease of the pumping ability of the gallbladder. So you can kind of liken it. I hate making these analogies because you can always find some things wrong with them, but you can kind of, if you're really thinking about it, you can kind of analogize it to like dysphagia, where you've got like achalasia of the esophagus. It's not pumping properly, and so you're getting this pressure sensation in your esophagus. This is kind of similar with biliary dyskinesia. Something's not working properly in the biliary tract. It's not a stone. It's not a problem from the, it's not a Acalculous cholecystitis based on our history, but there is something that is blocking there's something that's blocking the biliary tract, but it's not a stone. You can kind of think of it along the same lines. When we think about the esophagus, we think of mechanical blockage versus blockage that is more neurological from the peristalsis. It's kind of the same thing here. So this is biliary dyskinesia. And the next best step will be a HIDA scan. So usually you see this in patients who come in and you're thinking, okay, they've got cholecystitis, I'm going to do this right upper quadrant sound, and I'm going to find a stone, and I'm going to find a thickness, and I'm going to find pericholecystic fluid, but you look at the gallbladder and lo and behold, it's normal. Biliary dyskinesia then becomes your next most likely diagnosis. So this is disordered motility, contraction of the biliary tract, or abnormally high tone at the sphincter of Oddi, resulting in pain. And the presentation always includes right upper quadrant pain and usually nausea. Otherwise, it's variable. They may have fever, they may have elevated white counts, they may have disturbed liver enzymes, but that might not be present. But what you don't see is a remarkable right upper quadrant ultrasound. Their right upper quadrant ultrasound looks normal. And so at this point, you can rule out acute cholecystitis, because acute cholecystitis, you have to see the stone and you have to see the thickness of the wall, and pericholecystic fluid helps too. So the best diagnostic test, if you suspect biliary dyskinesia, and the next best step for this patient, is a HIDA scan. And HIDA stands for something I don't know. HIDA was the chemical that they used to use a long time ago. And you're going to do the HIDA scan with CCK, cholecystokinin. And what cholecystokinin does is it's supposed to contract the gallbladder to get the bile out. And if your gallbladder is not working properly, what you will wind up with is impaired gallbladder emptying. The treatment for this, if the HIDA comes back normal, is elective laparoscopic cholecystectomy. Other procedures exist as well, but this would be your procedure of choice. So here's a HIDA scan, and what's happening is you're giving the patient the contrast, and once you get it into the gallbladder, which you do right about here, it's full. So the gallbladder is right here. Here it is, full. Actually, I can't tell here. I don't have a lot of. One of these is the gallbladder. I think it might be this one on the top. Okay, so the gallbladder. No, that's this one on the bottom. Okay, so this is the gallbladder, and all I want you to see here is that there's no change. The gallbladder is not emptying. There's fluid in the gallbladder, and it's not emptying. What you should see is a gallbladder that empties. You should see fluid in the gallbladder, and then the contrast leaves, and it is no more. So I don't expect you to be shown a HIDA scan on the USMLE, but what I do want you to know is sort of the idea of what biliary dyskinesia is, and it's an ability of bile to move out where it should. It's not, things aren't working around there. It's like a constipated biliary tract. Okay, hopefully that didn't confuse you. All right, vignette. We got our same patient here, another universe. 46-year-old woman presents with ED, complaining of nausea and pain in her abdomen for 6 hours. Nice change of bowel habits or blood in the stool. No surgical history, mildly febrile. Physical exam reveals an overweight woman in moderate pain. There is scleral icterus. Abdomen is tender to pain in the right upper quadrant, but non-tender elsewhere. The abdomen is non-distended, bowel sounds are normal. This is the exact same patient we had earlier, except one extra thing. What is it? Scleral icterus. And this, when we see this in the same patient, we're thinking something entirely different. We're still going to get our labs. So our labs show elevated white count. CMP is a very high alkaline phosphatase, mildly elevated T-bili and AST, and elevated amylase. Beta HCG is normal. UA is unremarkable. Chest X-ray is unremarkable. EKG shows sinus tach. And the diagnosis here is choledocholithiasis. And why do we know it's choledocholithiasis? Or why is this not just in the gallbladder, neck, or in the cystic duct? Because we have jaundice, icterus. When you have a blockage in the common bile duct, the bile can't get into the duodenum. And so it gets blocked up into the liver. When it's just in the cystic duct, it's just being backed up to the gallbladder. Everything else from the liver can flow through normally and go through the common bile duct. You're just not getting stuff from your gallbladder. When it's in the common bile duct, the liver is blocked too, and so is the gallbladder. And if the liver is blocked, that's a big problem, because if the liver is blocked up, you're still going to be producing bilirubin, and ultimately that bilirubin is now going to go into the blood. And so you have an elevated bilirubin, and it's going to be elevated to the point where you'll have icterus. And so you'll have jaundice. So anytime you have a patient with right upper quadrant pain, fever, and jaundice, then you're thinking a block somewhere in the common biliary duct, as opposed to in the cystic duct or in the neck of the gallbladder, where you don't see jaundice. Okay, the amylase here is elevated. It can also be elevated in acute cholecystitis, so that doesn't necessarily mean anything. So choledocholithiasis is an obstruction of the biliary tract at the level of the common bile duct. There's a similar presentation to cholecystitis in as much as there's right upper quadrant pain and fever, but this is often accompanied with jaundice. Now, it's very difficult sometimes to see jaundice if you're just looking at the skin. You need to look into the patient's eyes, because if a patient just has mild elevation in their bilirubin, they're not going to have yellow skin. They're going to have scleral icterus. That will happen before they get jaundice. So look into their eyes. Fever and hypotension may be present as well. However, this is going to require completely different management, which I will talk about in the next segment. So the best initial diagnostic step is a right upper quadrant ultrasound, because this patient has right upper quadrant pain and a fever, and especially now because she's got jaundice. And make sure that you appropriately visualize the common bile duct. So if you're just putting it over Murphy's point, to say, if you can call it that, you're not going to see the common bile duct. So you're going to need to visualize the abdomen too and find the common bile duct. And what you'll find is a stone in the common bile duct as well as ductal dilation. The treatment for choledocholithiasis is an ERCP, endoscopic retrograde cholangiopancreatography, I believe that stands for, with sphincterotomy and retrieval of the CBD stone. So what you're doing here is the ERCP, it looks exactly like your endoscope that you do for an EGD, and you're putting it down the exact same way. You're getting all the way to the second part of the duodenum, through the stomach to the second part of the duodenum, and now you have another tool that comes off of that, and that's going to be able to get into the ampulla and to the common biliary duct. And from there you can retrieve the stone, you can break the stone, you can also inject a dye into the common bile duct, and that will allow you to visualize the biliary tract. One of the big complications to this is if you inject the dye into the pancreatic duct instead, you can cause acute pancreatitis. And then because they have they've got stones and it's created symptoms, you'll want to suggest them for elective laparoscopic cholecystectomy. And here's a stone in the common bile duct. Another one. Okay, another vignette. 46-year-old woman presents to the ED complaining of nausea and pain in the abdomen for the last 6 hours. She denies any change in her bowel habits or blood in the stool. No surgical history. Febrile at 103.6. Blood pressure 135/90. Heart rate 103. Physical exam reveals an overweight female in moderate pain. There's scleral icterus. Abdomen is tender to palpation in the right upper quadrant, but non-tender elsewhere. The abdomen is non-distended. Bowel sounds are normal. While waiting for sonography, she becomes increasingly somnolent and her blood pressure has dropped to 96/55. Additionally, additional IV fluids are started and her blood pressure comes back to 115/90. She remains somnolent. So what do we see in this patient? Well, we see pretty much everything we see in choledocholithiasis plus some things. We see an elevated, we see a fever, a little bit higher. This is a high-grade fever, 103.6. But we also had an episode of hypotension, and it wasn't just hypotension because she was throwing up or because she had diarrhea. She was already started on IV fluids. Doesn't say so in here, but you should assume that she was started on IV fluids considering that she's been in the hospital. But anyhow, patients should never drop down to 96/55 when they're in the hospital. IV fluids were started and her blood pressure came back to 115/90. What was that? That was a hypotensive episode. What also does she have? She's got somnolence, and she continues to have somnolence. What is that? That's an altered mental status. Now, there's two different things that you need to be aware of when we're thinking about stones in the common bile duct. The first is called the triad. I'm trying to remember whose triad it was. But anyhow, that triad was fever, right upper quadrant pain, and jaundice. That tells you that it is choledocholithiasis. As opposed to the triad, there is a pentad, and that pentad is right upper quadrant pain, fever, and jaundice, but also adds to it the altered mental status and the hypotension. If you have that pentad, then you've got acute ascending cholangitis, and all of these labs are the exact same as the patient before. So the labs aren't going to be any different. So acute ascending cholangitis is pretty much a clinical diagnosis, apart from the fact that, yes, you have looked in their right upper quadrant and you've looked at their common bile duct and you found a stone. A patient with acute ascending cholangitis is a patient with choledocholithiasis who also has hypotension and or altered mental status. This is, like I said, the same patient just with an added 2 symptoms. The fact that she has those 2 symptoms, or even if it's just one of those 2 symptoms, means that the management is going to be totally different. Reynolds pentad was the name of the pentad, and I think it's Virchow's triad. I didn't write that down. Okay, so acute ascending cholangitis. This is a medical/surgical emergency, and the patient will present with the symptoms of choledocholithiasis, which are the right upper quadrant pain, fever, and jaundice. However, they will also have additional signs of hypotension and or altered mental status. And it is absolutely critical that this be addressed as soon as possible. Hopefully, we've already diagnosed them with choledocholithiasis, but we might not have. If you've got a patient with right upper quadrant pain, fever, jaundice, altered mental status, and or hypotension, you're going to stabilize that patient and you are sending them for emergency surgery. The best first step, of course, is going to be IV fluids and hemodynamic stabilization. We want to keep the patient alive. The next step is going to be laboratory workup, blood cultures, and then immediately start broad-spectrum antibiotics right away, because we're concerned about sepsis here. That's why they'd be getting hypotension and altered mental status. So you want to get those labs done as quickly as possible and get your blood culture and then start IV antibiotics. And the reason why we wait to start IV antibiotics is because if you put the antibiotics into their blood and then you try to run a culture, it's not going to work. But if for some reason you can't get, if the labs are taking too long, they're not getting down there, your phlebotomist isn't getting down there to do this stuff, just forget it. Just start IV antibiotics right away. The treatment is sort of the same way as you make your diagnosis. So the treatment is going to be urgent biliary drainage as soon as possible. And there are some people who say that you can wait if the patient stabilizes. However, some clinicians like to do it as quickly as possible because this is such a typical presentation. You don't see it in anything else. The ultrasound and the clinical presentation, and especially if you have the labs, is usually enough to make a diagnosis. And so the treatment is going to be urgent biliary drainage for patients with AAC. And this can be done either percutaneously, but usually it's done via ERCP. And it's just like what you're doing with choledocholithiasis. You're going right in there and you are breaking up the stone and decompressing the biliary duct. Elective cholecystectomy should follow once the patient has recovered. Okay, here's another vignette. A 46-year-old woman presents to the clinic complaining of repeated episodes of abdominal pain as she points to her right upper quadrant. She says, okay, now, first off, note, this is in the clinic, not the ED. She says that the episodes often come on after having a larger meal or anything deep fried, but they go away within 10 to 20 minutes on their own. She denies changes in bowel habits or blood in the stool. She has no surgical history. She's afebrile. Blood pressure 120/80, heart rate 70. Physical exam reveals an overweight female and no apparent distress. Abdomen is non-tender and non-distended. Bowel sounds are normal. And just for the sake of this, we'll say that the rest of the physical exam was normal as well. This is biliary colic. So biliary colic is a patient who gets acute cholecystitis, symptoms we would expect with acute cholecystitis episodes every so often, but they go away on their own. They don't get the fever, but they get that typical right upper quadrant pain. And they also fit the typical set of patients that get cholecystitis, which would be fat, female, fertile, and 40. So the big thing here, though, is that there's a specific thing that she knows triggers this problem, which is a larger meal or anything deep fried, and the pain goes away on its own within 10 to 20 minutes. If the pain didn't go away within 10 to 20 minutes, you can bet she wouldn't be coming into the clinic, she'd be coming into the ED. So the fact that she's even in the clinic tells you that this is a repeated problem, but it's not something that affects her every day or for 8 or 9 hours a day. Okay, so biliary colic, what it is transient blockage of the cystic duct. So you are getting a problem with your gallbladder similar to what you would have with acute cholecystitis. The difference is it's a transient blockage, and so it goes away. And why does that happen with the fried food and the fatty food and chocolate and all those delicious things that we're not supposed to eat? The reason it happens is because your liver, remember back to physiology, your liver constantly is giving bile. Your gallbladder only gives bile, but it's very concentrated bile, after you've eaten a large fatty meal. And so after she eats this large meal, her gallbladder is contracting, but she's got a stone blocking it. So it's contracting against a pressure, and now she's getting this pressure on her gallbladder that's causing the right upper quadrant pain. So usually the patient is asymptomatic at presentation because they're not having an episode, but they will note to you on history a continuous pattern of right upper quadrant pain, and a lot of times they can link it to certain foods. It doesn't happen when I'm eating an orange or if I'm eating breakfast, cereal, oatmeal, but it does happen if I eat breakfast, if it's eggs and pancakes and sausage and bacon. So usually linked to certain foods. The pain resolves itself within an hour, but usually it's a lot less than that. The best diagnostic test, again, here is a right upper quadrant ultrasound. You're looking for stones because stones are the problem here. It's just that you don't have full blockage of the duct, you have just this transient blockage. And stones should be visible, but the gallbladder is going to be normal. You don't have acute inflammation of the gallbladder, so the wall of the gallbladder is going to be normal. The treatment of choice for biliary colic is elective cholecystectomy, which the patient can she can do whenever she wants. So this is elective cholecystectomy. Of course, with biliary colic, she is at long-term risk of ultimately going on someday to develop acute cholecystitis. So it would be advisable to get the gallbladder taken out for reasons other than pain relief. So here is a stone on the gallbladder, but we see no wall changes. No wall changes. All right, so what's our algorithm? So let's sort this all out. So we have a patient, like these initial patients that came in with right upper quadrant pain, but they didn't have any jaundice. What we do first, our labs, CBC, CMP, amylase, beta-HCG in a woman of reproductive age, which would be probably 12 to 55 if you're going to draw wide margins. Urinalysis, especially in women, but in anyone really, chest x-ray and EKG. You can get those labs in everybody. EKG maybe more in older adults, but this would be a good battery of labs to get. When these come back suspicious for right upper quadrant or for acute cholecystitis, or even before you get your labs, you're probably going to be doing a right upper quadrant ultrasound. And the three ways that these can come back, they can come back unremarkable, which if they come back unremarkable, then we've ruled out acute cholecystitis or any kind of cystitis. And what we're going to check for is a HIDA scan with cholecystokinin, because if there's no stones in the gallbladder, we don't have acute cholecystitis, we don't have choledocholithiasis, we don't have anything. The only thing it can be is biliary dyskinesia. So we get this HIDA scan, which remember checks how the gallbladder is working. If it's normal, well, then we're kind of out of things in the biliary tract, and you should consider alternative diagnoses. That's why it's important to have all these labs to begin with. If it's abnormal, then you should make the diagnosis of biliary dyskinesia, and treatment for that can be elective laparoscopic cholecystectomy, whenever the patient is ready for it. If, however, you see stones in the gallbladder neck or in the cystic duct, and there's wall thickening, and if there's pericholecystic fluid, then you know that you have a blockage. And this is what's causing the pain, and the fact that you have the thickening and everything means that there's inflammation. This is acute cholecystitis. What we're going to do for these patients is we're going to observe them, admit them, place them on IV fluids because they're going to be NPO. You can place an NG tube for decompression, so you don't get any, if they've just eaten a lot, you can take that stuff out so that they don't get any worsening pain. Most importantly, give them IV antibiotics and then observe them for 48 hours. If the symptoms resolve, they should get an elective laparoscopic cholecystectomy. It says within 6 months. That's the recommendation by some group, but I'm going to tell you that most surgeons want to do that cholecystectomy within the same visit. If the symptoms persist or worsen, then you're going to do an urgent laparoscopic cholecystectomy to remove that acute cholecystitis. If on right upper quadrant ultrasound you have a patient without jaundice, but they have a stone in the common bile duct, which if there's no stone in the gallbladder or in the neck, you should always check in the bile duct just in case. Then if there is, the patient will be diagnosed with choledocholithiasis. Remember, most patients who have choledocholithiasis will also have jaundice or scleral icterus, but you'll want to check anyway. So if there is a stone in the common bile duct, then you diagnose them with choledocholithiasis. So what if they do have right upper quadrant pain plus jaundice? We're going to get all those same labs. However, we might want to add to that blood cultures because a lot of these patients already have or may be at risk for acute ascending cholangitis. What we're going to do initially is going to depend on how healthy they appear. If they are normotensive and they don't have any altered mental status, you can go ahead and make the definitive diagnosis of choledocholithiasis with a right upper quadrant and transabdominal ultrasound. The reason I say transabdominal is because the right upper quadrant alone, where you're looking for the gallbladder, you're going to have to look other places than there to find the common bile duct. And if you find gallstones in the common bile ducts, as well as ductal dilation, which is just a sign that you've got pressure building up before the stone, then you have a diagnosis of choledocholithiasis. You should admit them, put them on IV fluids, NPO, IV antibiotics, and observe them. Ultimately, though, they will need ERCP to break up that stone. Doing an elective laparoscopic cholecystectomy is not enough because their stone is in the common bile duct. It's blocking stuff coming in from the liver, as well as the gallbladder. So you'll need to do an ERCP to break up that stone, and then that can be followed by an elective lap chole. If you do that right upper quadrant transabdominal ultrasound and it's negative, do a CT. CT is a little bit better for finding the stones in the common bile duct. You're not ever going to get a CT with if you're looking for stones in the gallbladder or in the neck, just because ultrasound is so good for that. But with looking in the common bile duct, it can be a little trickier. So if you don't find any, you should still get a CT, just to totally rule it out. Now, if this same patient came into you and they're hypotensive or they have altered mental status, of course you're going to resuscitate them and then you're going to start IV antibiotics as soon as possible. At this point, you've diagnosed them with acute ascending cholangitis. I wouldn't even worry about, at least for the test, I wouldn't worry about ultrasound. In the real setting of the, for real life, you're probably, yes, going to get an ultrasound while they're prepping the room for surgery, just because you can make sure. But when a patient has acute ascending cholangitis, they need emergent treatment. So you're going to give them IV fluids, NPO, IV antibiotics, put in a Foley because we want to make sure we're monitoring their hydration. And if if they're refractory, we're going to be doing an emergent ERCP, which by emergent I mean ASAP. If they've stabilized, then urgent therapy, which by urgent I mean probably with as soon as possible. So emergent basically means you're going to call the surgeon in regardless of whether they're there or not. You're going to wake them up in their bed at home. Urgent means as soon as they get into work. So this is sort of what I was telling you about how with the official recommendations, they with admission and IV fluids and IV antibiotics, you can wait for stabilization or just go in for the ERCP. But most of the time in clinical practice, you're going to do the ERCP right away. So what I want to emphasize here, though, is that with acute ascending cholangitis, the next step in therapy is drainage of the biliary tract. Whereas with choledocholithiasis, it's to remove the stone. With acute ascending cholangitis, it's drainage of the tract, because what do you have in the biliary tract in AAC that you don't in choledocholithiasis? You have infection, and that infection is going to continue to cause sepsis. So you want to drain that as quickly as you can. Then you can put them in the ICU for observation, and of course, ultimately, you're going to be removing their gallbladder. So hopefully these two make sense in contrast to one another. The way we approach AAC is similar, I guess, in principle to how you approach acute cholecystitis. They don't want to really mess around with something that's acutely inflamed, but if there's really, really bad problems, you're going to do surgery. It's better than not doing it. But if you can get them stabilized, you want to try to put it off as long as you can. So that's sort of the principle behind it. But if you can memorize these algorithms, you'll know everything you need to know for step 3, and certainly everything you need to know for step 2. And finally, okay, so complications. Emphysematous, don't worry about knowing exactly what these are. Just know that these things can happen. So any patient who's got inflammation or infection of their gallbladder or of their biliary tract, you can get emphysematous cholecystitis. This would be a long-term complication. That would be colonization of the gallbladder with anaerobic aneurysms, or anaerobic organisms resulting in air in the gallbladder wall. It's diagnosed on ultrasound. Don't worry about knowing what that looks like. This requires urgent cholecystectomy as well as the usual treatment, antibiotics. Gangrenous cholecystitis, this is extreme inflammation of the gallbladder wall, causing thrombosis of the cystic artery. And when you get thrombosis of the cystic artery, that's going to result in a cutoff of flow and ischemic necrosis of the gallbladder tissue. This is also diagnosed on ultrasound. This will require urgent cholecystectomy along with usual treatment as well. For a perforated gallbladder, this is where the gallbladder gets a hole. And this is going to result in biliary and septic biliary spillage, perhaps, into the peritoneum. And the symptoms here will be peritoneal symptoms, because now you've got an aggravated peritoneal space. And that's not typical in any other any gallbladder that's not perforated. So if you have peritoneal symptoms, then you are concerned about a perforated gallbladder. You diagnose this on ultrasound as well as with the symptoms. This also will require urgent cholecystectomy as well as peritoneal lavage and the usual treatment. Okay, a few last words. When you are writing your notes in the hospital or typing them on the computer, and especially for step 2 CS, if you suspect any of these things and you're writing that out on your differential, avoid using acronyms. You should avoid using acronyms in general. I know I use them all the time, but this is for review. This isn't for a nurse to do her treatment patient or for other doctors to read. This is just for review, but you should avoid using acronyms as much as you can. So, for instance, acute ascending cholangitis is oftentimes in the literature written AAC, but that could also mean acute Acalculous cholecystitis. Or asymptomatic cholecystitis could be written as AC. Acute cholecystitis could be written as AC. Acalculous cholecystitis could be written as AC. Or biliary dyskinesia could be written as AC because some of the more academics call it acalculous cholecystopathy because it doesn't have any stones in it. So avoid using acronyms for Step 2 CS and for real life, I guess, too. So if you have any questions, feel free to let me know.